Thank you very much for having me. So my disclosure is not related except for the fact that I'm a plumber. So I like to put things in things and open holes or close holes, both. So a little bit in terms of background, this is going to be about complex ASDs and whether we close or don't close them in the presence of pulmonary hypertension. I want to show you a comparison of the European guidelines versus the US guidelines. So the European Society guidelines are at the top. This is when do you treat an atrial septal defect. And then the American Heart Association, American College of Cardiology guidelines are here at the bottom. And you can see that they differ a little bit in that we all agree that if a hole is big enough to cause a hemodynamic issue, and that is whether there's symptoms or signs on imaging of RV overload, then it is reasonable to close it as long as the resistance in the lungs, so the pulmonary vascular resistance, is less than 3. And then in the US guidelines, there's more of a focus on QPQS, and I'm sort of in that team, so I'll go into that in a little bit more detail. Everybody agrees that for Eisenmenger physiology, when the pulmonary vascular resistance is greater than 5 Wood units despite therapy, or in the US guidelines, we think more about when there's net right to left shunt, so the QPQS is low, then it should not be closed. And then somewhere in the middle is where we're trying to find the right strategy. And that comes from the idea that we think that mechanistically, having an atrial septal defect and long-term left to right shunt that then increases circulation in the right ventricle and increases the pulmonary circulation might lead to over-circulation that may cause vascular injury that then over time increases fibrosis in the lungs and decreased contractility and the dilation of the pulmonary arteries, which can lead to injury and then chronic PH. And we see that in patients who have long ASDs for a long period of time, but we also sometimes see pulmonary hypertension develop in patients after successful ASD closure. And depending on the definition that's used, the mean PA pressure greater than 20, up to 60% of patients had a mean PA greater than 20 within many years when they're followed regularly after ASD closure. And then if we have a more stringent cutoff of a significant elevated pulmonary mean PA pressure greater than 35, is up to a third of patients, so that's a lot. And that can say something about, well, when were the patients treated? What if we closed every ASD when kids are 3 years old? Would we still see pulmonary hypertension later in life? And we don't know. But it also says something about the general population that we see. And did some of these patients develop left heart disease? Because everybody and their mother nowadays has some version of HFpEF, so maybe it's all LV dysfunction. Or maybe there is something mechanistically or genetically about patients who were born with atrial septal defects, and that may also affect their pulmonary vasculature. And so this was an interesting case. This was a lady who was 40 who presented with a new O2 requirement after a C-section. The first thing that she had, and I should have asked the audience, but she had a CTPE because that's the most common, either a clot or an embolus from amniotic fluid. But the CTP did not show any clot in the lungs. But this shows us an atrial septal defect. And so she had an echo afterwards that showed a secundum atrial septal defect. Her sats were in the 80s at rest. Were in the high 80s at rest, and then with exertion, we're going down to the low 80s. So she was discharged on oxygen. We know that after pregnancy and after delivery, the pulmonary vascular resistance is usually higher. So that's a high-risk time for any patient with an ASD, congenital heart disease, or especially worried, or pulmonary hypertension, of course. We're especially worried for them towards the end of pregnancy and early in the postpartum time. And so we said to discharge her on oxygen. Hopefully her PVR, as she goes further away from the delivery, is going to get better with time, and then we can figure out what to do for the ASD. She was on low-dose diuretics, was doing better. This is a few months later. On Roumare conscious sedation, we did a right heart cath. Her sats on Roumare were in the high 80s, so they'd gotten better. But her pulmonary pressure is still very high. So her mean PA pressure is 55, her wedge was 15. And I didn't, for some reason, the cardiac output, I think, was cut off, but her cardiac output was low normal. And so let's see if we have it here. I think this is the continuation of that same cath, sorry. So here it is. So her cardiac output, her pulmonary blood flow was 4.1, and her systemic blood flow was measured at 3.7, giving her a FIC QPQS of 1.1. So it really reflects bidirectional flow. And her transpulmonary gradient was high, and her PVR was calculated at somewhere between 6 and 10, depending what measures we use. The appropriate measure, of course, would be FIC would be more accurate in this setting, given the shunting. Put her on 100% FiO2 and on nitric, and that made things a little bit better, but still a high PVR. So what would people do at this point? No. She has an ASD. Should I close the ASD? No. Thoughts? Treat? Yeah, so that's what we wanted to do, is start on pulmonary vasodilators and see what happens to her physiology. A few images from her baseline transthoracic echo. RV is dilated, there's septal bounds, suggestive high pressures. This was the view of the atrial septum. So on transthoracic echo, it's oftentimes hard to see the atrial septum well, and we can sometimes miss significant atrial septal defects. Hers was reasonably well seen and looked like it was a typical secundum, but it was pretty close to the posterior wall. And I had looked at her CTP as well, and even on that CTP, it looked like the ASD, where it was in the secundum area, but it was very close to the posterior wall. So I actually did an intracardiac echo at the time of this diagnostic cath. Typically, we do the intracardiac echo with more sedation. We do it from the femoral vein, but we can also do it through the IJ. It's actually the same size sheath that we normally use for a right heart cath. It's a 7 or an 8. And on intracardiac echo, we could see that her atrial septal defect was quite large and it was very posterior, really hugging the back wall of the heart. And that's the one that's the hardest to close with a device, because it really has to splay the device, and the devices want to be straight, and if you are forcing them to splay on the posterior wall of the atrial septum, you really worry that it's going to erode in either the right atrium or the left atrium. So that was the one that unfortunately did not have a great transcatheter anatomy. Which ups the ante a little bit. Because she doesn't have a posterior rim, we're thinking that if we're going to close this, it's going to have to be in the OR. And so she was started on ambrisentan, selexipag, and tadalafil, and then brought back several months later for another right heart catheterization. At this point, her filling pressures are still good, but her transpulmonary gradient has improved, but it's still, I think it's 28, and then her cardiac output at that time was about 4 point something. So a little bit better on therapy, but we still have, what did I write? A QPQS that's a little better, but still less than 1.5. So she still has some amount of bidirectional flow, and her PVR is now between 3 and 4. So what do people do now? I see nodding and frowning, which is what we're doing. We're frowning a lot. Not great. When she was, interestingly, when she was desatting right after the C-section, she was kind of feeling fine. She was desatting but feeling fine. And now that she's on 3 drugs, she doesn't feel great. She feels her exercise capacity is lower. Now, some of that could be just the changes over time, but she still has exertional symptoms and doesn't feel great. So what we were thinking is that even on these drugs, her QPQS is less than 1.5, meaning overall, right now, when we can measure it, still most of the blood, there's not that much blood flow that goes left to right and further overloads the lungs. Still there's a little bit, but still she has a lot of blood flow that goes in the other direction. And if we were able to completely close the ASD, we could reduce that QPQS, but she would still, basically the difference that we would make wouldn't be huge, because she's still starting at a spot where it has a lot of left to right shunt and not that much. She's starting at a spot where she has a lot of right to left and not that much left to right. So even if we can take that away, we're not going to be able to protect her lungs all that much. We're not going to make her pulmonary vasculature so much happier. A little bit better, but not a lot better. But she still has quite severe pulmonary hypertension that is probably not going to go away just because the volume load is better. So the way that I could test this is with a balloon. The balloons are pretty big and bulky, and I think I have some pictures for the other case. But they take up a lot of space in the left atrium, so sometimes we'll see left atrial pressure or wedge pressure elevations just because the balloon is in the way and reduces the area of the left atrium, which makes things a little bit false. And we can keep the balloon up for a period of time. Nobody really knows how long, like 5 minutes. Is that enough to see a difference? Some colleagues in Europe will say, oh no, we leave the balloon up for 15 minutes. Is that enough? And the things that we can measure, we can pretty reliably measure cardiac output, so we can see if the cardiac output drops with a defect occluded. RV function is hard to measure. We've tried sometimes having a really good sonographer there, and they can put a probe on the RV and see how things change. I think the biggest limitation is the fact that we have a big balloon that will reduce preload a little bit because it's also in the way. It's a balloon that comes from the IVC, goes through the atrial septal defect and goes to left atrium, and sometimes that's enough to reduce your IVC flow, which is a good thing, so your numbers will be better than you really think that they are. If there are people to do this really well, is you can put a closure device in there and not release it, so it's still connected to the cable, and you can take it out if you don't like it, and then just see what happens. And then that's a little more natural. You don't have a balloon in the atrium. The problem is that's expensive. The devices are thousands of dollars. But in a defect that we think transcatheter is easy to close, you can put a device in, then wait and see what happens before releasing it. Once we put a device in and send the patient home, before the device is endothelialized, so within that first month or so, they're not that hard to remove, although we really hate to do that, so that's not something we think about, but there's ways to reverse that in a way. If you put a device and you don't like it, you can fenestrate the device. You can make another hole depending on the anatomy and how big the atrial septum is and how big your device are, so it's not completely irreversible, but obviously the more that we can think about it ahead of time, the better it is. And I think that's what changed our thinking about her a little bit as well, is the fact that I didn't have a great transcatheter option for her, and we were really worried to send her to the OR for an elective cardiac surgery with these hemodynamics, knowing that she's 40, and we didn't think that we could totally fix her pH based on this. Interestingly, she actually has two sisters. One of them has a large PFO, the other one has an ASD. One of her sisters was diagnosed early in life with the ASD and had it closed when she was 20, I think, and her PA pressures are fine. But she was unlucky to be diagnosed later, and whether there's a genetic component or not. The genetic testing is pending. We don't have it back yet. We still don't know. And so this is another case that was a 35-year-old who was progressively short of breath, went through the different stages of the workup. Eventually was found to have a large atrial septal defect. 20 millimeters, a pretty large, on static measurement, is a pretty large secundum, and also a large PFO. She was appropriate. I don't have her hemodynamics before the Remodulin was started, but was appropriately started on Remodulin, Ambrisentan, and tadalafil, and this is what her hemodynamics were. So a QPQS that was greater than 1.5, so 1.5 to 1.6, but still with a high PVR. And interestingly, she had the genetic mutation and was found to have a SOC17 mutation that her son also has. Her son does, at this point, is followed in pediatric pulmonary hypertension and does not need treatment. But that changed a little bit the way that we were thinking about her. And she was quite symptomatic. She was very short of breath, was desaturating with exercise. So we actually balloon sized, and this is what the balloons look like. The numbers are very small here, so I can't see them. I don't know how well they're projecting. But this was measuring at 20 to 22, the waist of the balloon through the large ASD. And you can see how bulky this is inside the heart. Oops. And then this was actually a balloon through the PFO, which was smaller. And the fascinating thing is that when I occluded her PFO, she actually felt better. I didn't tell her what I was doing, but she was like, oh, I don't know what you just did, but my breathing feels better. My chest doesn't feel heavy. She literally said, this is the first time in 5 years that my chest feels better, and I feel like I can take a full breath. And that did not happen when I was occluding the ASD, which was also interesting. And so for her, we were thinking whether actually she might be a candidate to at least close the PFO and reduce the amount of blood flow that she had, because her QPQS is greater than 1.5. And obviously 1.5 is a pretty empiric number that we choose. Does that really, those 0.2 of QPQS make a difference? But at least in her, it seemed like her defects were large enough that we think that the extra volume load made a difference. And we thought that it might make sense to actually try to close one of these and reduce the amount of left to right flow that she had for symptom improvement. We knew, and she was very clear, she knew that this was not going to be able to take her off her meds. It probably wouldn't change her life expectancy or the potential need in the future, given how young she is for further therapies, including transplant. Unfortunately, she's allergic to basically every metal under the sun, including nitinol, nickel, which is what all of our devices are made of for now. And so she actually, once we sent her for nickel patch testing and she's allergic, we couldn't do this. But her physiology was different than the first patient.
Did she go to the OR?
No, we were too worried to do it. And I'm curious, actually, would you send her to the OR with someone to do a fenestrated closure?
On her hemodynamics, but it was just that she felt better when you did something. And we've run into this same issue with nickel allergy. So I was curious to hear what ultimately happened with her.
And it might be, I think, that our concerns about going to the OR is cardiopulmonary bypass is not good for the heart in general. So there's always RV ischemia on bypass because it's harder to do coronary and myocardial protection. So there's the bypass hit, there's the fact that there's always some small injury to the lungs, and so the PVR is always higher coming off bypass and coming out of the cardiac OR. And this would have to be done on bypass. There's no other great way. And so if we think that we could support her well through that period of time, and by we, I mean if I think Dr. Wong could support her well during that period of time, then I think that might make her feel better. I think all of us are very scared about putting a PH patient on pump. And so I think in general, I don't want to belabor the point, but in general, I think that it really is variable whether in patients who have atrial septal defects and pulmonary hypertension, the atrial septal defect kind of helps. Like in patients who have Eisenmenger physiology, they can decompress the right heart through the ASD, and it's probably actually helpful by the time you reach the end stage of the disease. Or is it something that's not helpful because you still have LV, left atrial to right atrial flow, and you still have overcirculation in the lungs that actually puts even more strain on those lungs, on those pulmonary vasculature that's already having a hard time? Or is it a total bystander? There are definitely some patients. I think some of that is related to the size of the ASD. So on paper, on an echo report, this patient has an ASD, doesn't mean anything until we see the size of it, which is sometimes hard to measure. And I think that's where intracardiac echo is quite helpful because, again, putting a patient with significant pH under sedation for a transesophageal echo is not always an easy thing to do. And it's much easier when cardiac anesthesia can be there. It's a slightly higher risk. So if we really want to see the size of it well, either a high-quality MRI can do it or an intracardiac echo to have an idea of the size. And if it's a small defect, then it doesn't matter. We don't think hemodynamically it can make a difference in anything. I think it's just helpful by the time they reach Eisenmenger. And there is good data to show that Eisenmenger has better prognosis than idiopathic PH. And whether a lot of that is the genetics, which it probably is, and I think I'm glad there's people in this room who are working on trying to figure that out, or whether there's the hemodynamic effect as well, I think it's still an open question. I'm sure there's different patients, and we still don't really know how to tell them apart, but I hope that in the future we will be able to be more personalized in terms of the care that we give them. Some of the genetics that we had talked about before, there are several genes that we know, and then in congenital heart disease, there's also syndromic association. So if I see someone who has pulmonary anomalous venous return, or for example, Scimitar syndrome, or they have Downs or DeGeorge and so on, then it's a slightly different category already. And then the medical therapy, of course, this is really important because a lot of the data that we have from before on atrial septal defects and PH is in the days when we had 1 or 2 drugs. The medications are so much better now that treat to close is probably going to be available for a lot more patients. We couldn't treat them with a lot 10 years ago, which is when a lot of the data I'm showing you is from. So there's actually a national consortium trying to repeat those studies and look again at ASD patients. If we treat them, when can we reach a PVR that's in the 3 to 4 range? And now can we close the ASD and see what happens? And when I talk about the hemodynamic assessment, I think that was brought up a little bit, is how do you assess them? Do you assess them on room air? Do you try to do the test balloon occlusion? Do you want them in the ideal physiologic state? So do you want to put them on oxygen and see what happens? And the answer, I think, is to do it on both. I want to see what they're like on their regular day when they're walking around, but I also want to see how good I can make them. If I can normalize their filling pressures in the lab and also put them on oxygen and maximally vasodilate them. And then, because as I mentioned, the QPQS can change a lot, so studying them is helpful. And this is a treat-to-close algorithm, which is the study from several years ago that we're now trying to repeat to see if after treatment patients can feel better. There's not a randomized study, and there's never been, but something to think about how we can be cautious in interpreting the data. The things that we sometimes do, we oftentimes will do a cardiopulmonary exercise test, and we'll sometimes do the cardiopulmonary exercise test with radionuclide imaging to try to assess RV reserve, which, especially before we send someone to the OR, is very helpful. The radionuclide testing is a MIBI, so it's not a perfect assessment by any means. If we had high-quality echo or even better stress MRI, that'd be so much better. But the more that we can assess with exercise, the better it is. And then also always discuss this in a group with our PH team and our surgeons and our whole congenital team. In terms of the options, we thankfully have many. We now have, there's not an FDA-approved fenestrated device, and so if nowadays we want to get a fenestrated device in transcatheter, we actually take one of those off the shelf and make a hole in it, which is not very scientific, but we make a hole that we think is big enough. Some people would argue that if you're going to take a patient to the cath lab and you may not even need to intubate them, we don't know that a small fenestration, like a 2 to 3 or to 5 millimeter fenestration, makes a huge difference. And the post-op patients, we think it makes a huge difference because, again, the RV injury being on pump in the lungs and so on. In a cath lab patients, if you think that you can close their ASD, you should just go ahead and close it. But we sometimes still want to leave a small fenestration. There is a device, this one is the Oclatech device that we can get compassionate use for and still use in the US. There's a couple of pediatric groups that have used it, and if we needed it, it is available. It has a bigger fenestration that seems to stay open for a longer period of time, and that's been the main issue when you take a random device off the shelf and try to make a hole in it, is that endothelialization over the device can just close the fenestration at a very unpredictable pace. Great. What questions do you have? Comments?
Yep. Question in the back. Oh, Dr. Wertheim. Let's get you off.
Awesome talk. This is one of the issues that comes up that we always have these extended conversations about in the hospital, and it's a hard call, and I have a lot of respect for the folks like you that are having to make that call more often than me. What is your experience in the patient population that gets closed that doesn't do well, and the RV decouples, and you start to see problems? Is that a phenomenon that occurs further out? Is that something that's a little bit more, you see something sooner? I'm sure it depends on the individual patient, the exact physiology, but what's your sense of when you know that you're probably going to be out of the woods?
That's a great question. In full disclosure, I belong to the Mike Landsberg School of Thought, and so we have a really high bar to close these, in general, we have a high bar to close these, and so we're very selective, and the ones that we've done have done okay. In most patients, we find that if someone has already like exercise pH or something, but they're really symptomatic and we try it, we'll sometimes see people be a little more tachycardic and they feel kind of okay, but we are worried about them in the short term. In the more mid to long term, it's mostly that we think we took away a little bit of their reserve. Like on a regular day, they're okay, but what if there's something that will increase their PVR, like they get a cold or flu or COVID or something, or they need to go to surgery for something, and those are the periods when we're most worried about them. And then following them long term, I don't think anybody has great long term data, but that's something that they may develop a higher PVR and symptoms like they would just worsening pH in 5 years from now. But maybe they would have had it anyways, and that's where it's really hard to know, is that it might have happened anyways with their ASD, and maybe they're a little more symptomatic now than they would have been before, but we really wouldn't know. So we don't feel like we're ever out of the woods, unfortunately.
No, that's really helpful. And before I turn this over, I'll push you a little bit further. What PVR are you personally comfortable in that intermediate range where you start thinking about it? Because that's the 2 to 5 range, or so, there's a lot of heterogeneity in there, and especially as we consider how long it takes to develop a high PVR to begin with. And by the time you develop a high PVR, there's a large percentage of your pulmonary circulation that's compromised.
Yeah, that's a great question. I would say I'm at the lower end, so like 3 to 4, and it also depends on how many drugs there are to get there and how, if we think that we have wiggle room on therapy, because I think that's another part of the equation is, what if we close it and they get a little bit worse? Can I still affect their PVR, or am I kind of maxed on the medications that I'm on? I don't have a lot of wiggle room to go. How hard did we have to work to get to that PVR of 3 to 4 to 5? So I'm at the lower end of that spectrum. And then also, what is the QPQS? If someone has a PVR of 4, but their QPQS is 1.7, they have a lot of left to right shunt, I feel better about that. But if someone's pretty borderline and their PVRs, then I'm even more strict with the PVR number.
Thank you.
Anybody else questions? All right, so I think then Oh!
I was almost saved, almost.
I feel like I'm monopolizing this here. So, great talk. Thank you very much. So, we about 2 or 3 times a year we get the patient who has left atrial disease, and this is. Oh, did I steal your question? Sorry, Jane.
Go ahead.
So whether it's a kid or an adult, usually it's an adult, 80 years old, probably has underlying HFpEF, whatever, valvular heart disease, or they've just had a MitraClip or something and they've got a they've got a hole there, and they send them our way, say, you know, should we close this? They're shunting left to right. How do you manage those patients? They're pretty complex in my mind.
Yes.
Then most of them usually have PH, but it's, you know, it's post-capillary, and so, yeah.
I think that depends on what medical therapy they're on, and again, how much better we can make it. Also, from the left atrial hypertension point of view, I mean, in the last 5 years, our drugs for HFpEF are so much better, we think, and so I'm a little more confident now than I used to be about our ability to reduce their LA pressures and to make their diastolic dysfunction better, or their systolic dysfunction if it's someone, like you said, ischemic MR or something like that, and they had to clip. And oftentimes in the patients who are immediately post-clip or some device or something, they didn't have an ASD and we made one and now they're more symptomatic or their numbers look worse, we just close it because they didn't have it, we made it, they're worse, let's just get rid of it. And they're usually small and central and it's pretty easy to close. We have seen patients who had a small to moderate ASD for their whole life, and we never want to do anything about it. And now they're in their 70s. As exactly said, they have some HFpEF, their left atrial pressure are high, so now they're shunting more. And that ASD that used to have a QPQS of 1.3, 1.4, we didn't care, is now 1.7. So like, now he meets the threshold. And that's then we have to think about the balance of they're really symptomatic because their LA pressures are higher and they have high wedge and edema. And okay, they're also decompressing a little bit left to right, and that's actually kind of a good thing. But when the picture is murky and the defect is small, we'll say, well, let's try you on medical therapy, and if you can make your numbers feel better and you feel better, that's great. If things are still a little in between, we can close it and then really rely on medical therapy afterwards to, if they're willing to take the 6 drugs that people for HFrEF can be on, usually their symptoms can be managed with that. What do you think? Is that your approach as well? Dr. Leopold, what do you think?
Oh, yeah, no, I agree, because this is typically what happens. It's like getting hurt by friendly fire, because it's your colleagues who are doing this to you in the cath lab. So, I mean, just to follow up on that, so the flip side of the coin is, and you know these hemos better than anybody, is, how do you feel now about all of these devices that have come to the cath lab for patients with left-sided heart failure, where they have trouble reducing the pressures, and now they create the ASD?
Yeah, I think that's where sending them to our PH colleagues and having someone think about, from that point of view, if they're doing well or not. I mean, one of the early interatrial shunt, not early, I guess, when the last trial of interatrial shunts seemed that it didn't work, partially because they were including some people with some RV disease or had slightly high pulmonary pressures, and then those people got worse, and it kind of balanced out that some people got better. Right. And so doing that careful assessment, but it's really hard. I mean, we struggle that too with a tricuspid valve patient. So you think things look okay, and you implant a new tricuspid valve, and then they crash, and it was hard to predict. So I think there's a lot more that we can do on that front. I think they're expensive devices, and it's a procedure. But as long as it looks like the pressures can be managed to some extent with medical therapy, and the RV function at least looks good, sometimes getting that CPET and looking to see if we can show that the RV is still stable or maybe doing better with exercise is helpful. And sometimes you have to try and see what happens. And thankfully, all those devices are designed so that they're really easy to close afterwards if it doesn't seem like it works. But that's the last resort.
No, that's great. That's really great. Thank you so much for this terrific talk.